Hello, Dr. Brandon.
Hello, Dr. Morgentaler.
What you got cooking?
Well, I got some interesting stuff. Today, I got an article that I really want to get your opinion on because it sounds to me like it's suggesting that testosterone can cause cardiac issues.
Oh, no,
Yeah.
not that again.
So I want to talk about that. Um,
Before we start, a small disclaimer. The Sex Doctors podcast is not a substitute for medical or psychological advice.
but we'll do a question first. I'd
Great.
asked for some more psychology related or sex therapy related questions. And so we got a couple this week. So this person says, my partner has a much higher drive and keeps asking me for more sex. I feel pressured and I start to dread it. How do we renegotiate this so that I'm not looking like the problem?
Yeah. The old desire discrepancy issue,
Exactly.
right? One partner wants more than the other. Common? Is that common?
It is so common. It's considered typical, normal,
it's typical.
whatever. It's just what it is.
Yeah. Except for early in relationships when everybody seems to want it all the time.
That's true.
There's always got to be somebody who wants it, even if it's just a little bit more, a little bit less.
Yeah.
Or a lot more versus a lot less.
So that's what this person's feeling.
Yeah.
So, one of the things, so of course we could talk about this for hours,
We could. I
Yeah.
could talk about it for hours with you.
but I'm just going to give them a couple things to think about or
Great.
talk about. So one is, I think it can be helpful for couples to agree on how much sex they're going to have, at least be in the ballpark of it. Because,
Can I stop you?
yeah,
People are listening to that and they're going, what? Like this is like a signed contract, like an agreement? Isn't sex supposed to, Dr. Brandon, isn't
Yes.
sex supposed to be natural and come from,
spontaneous.
yeah,
Yeah.
spontaneous, come from the heart or the pelvis or something?
Yeah.
Right?
Right. Yeah. But here's what happens is some people have certain expectations, like let's say sex every day, and another person has an expectation of once a week, and it's just a constant fight.
Yeah.
Right. So it's usually not that disparate, but it can be. So I suggest that people kind of agree what's the goal for the week? Is it once? Is it twice? So that they're kind of in the ballpark and not always pissing each other off.
Right.
Okay. So that's one thing I would have them do.
Okay.
And then I also encourage people to come up with compromises other than intercourse. So they can have sexual experiences together that don't involve intercourse. And I would say the lower desire partner keeps their clothes on. So that can actually be very intense for everybody as long as the lower desire partner is connected and hooked into what's going on.
When you say keep their clothes on, why is that important?
Just because then the expectation of sex isn't there, of, intercourse isn't there. So the lower desire partner may well be able to sort of relax and enjoy the experience more, knowing that, it's not going to end with their engagement, their sexual engagement.
Got it.
Genitally.
Yeah.
Yeah.
Genitally.
Yeah. Is that a word? As I started it, I'm like,
genitally.
Yeah,
Sure.
okay.
Genitally speaking.
yeah. So, compromises other than intercourse can be anything. It could be the lower desire partner holding the higher desire partner while they masturbate, or the lower desire partner going down on the higher desire partner. If that feels like a compromise other than intercourse, but not for everyone. Not everybody feels that way. The lower desire partner can, masturbate the higher desire partner. They can, watch some porn together. They can play with sex toys. There's a gazillion sex toys out there.
These are a lot of options.
Right. And they all can enable the lower desire partner to stay dressed if that helps them feel more comfortable. So, for example, I'd be thinking, I don't know this couple at all, so it's really hard to say, but I'd say, why don't you two consider twice a week sex with the option once a week to do a compromise other than intercourse, but you have two sexual experiences together, like something like that, and see how that goes. So they would start that plan and then agree, like they're going to talk about it in a month, put it on the calendar. So this is the plan for the month. It's really kind of set in stone, but at the end of the month, you're going to discuss it. Did it work? Did it not work? What needs to be different? So that's what I would say.
I think that's very concrete and very helpful advice. But let me ask you the question that I think a lot of people listening might ask. There's a partner who doesn't want to have sex that much, right? And somebody wants to have sex more. So for the one who doesn't want to have sex that much, if the number of times per week that you're talking about is more than he or she is comfortable doing, how do you get them to, how do you
So,
approach that?
so I would be
Because
wondering.
some people are listening, they're
Yeah.
saying twice a week with maybe an additional kind of sexual experience 3 times a week. I say, I'll take that, right? Long-term partners. Um, like their wish, their hope is that their partner would be willing to
Yeah.
do that.
Yeah.
But it's hard to get them to do it. That's why they're having a problem.
Right.
So how do you get the lower desire partner to agree to all this?
So that's a complicated question, and because many the lower desire partner could have many reasons why they're feeling like that's too much of an effort for them.
Right.
But I would be thinking about things like having the higher desire partner talk to the lower desire partner about why this is important, because the lower desire partner may not understand this at all. They have a different experience of sex, probably. They don't understand what sex is for their partner. And so having a dialogue about what this really means for them, not just sex as an act, but what does it represent for them? What do they get from it? What do they experience with it? That sort of thing. So that can help so that the lower desire partner understands. Sometimes it's up to the lower desire partner to work on amping up their drive. So, we think about getting their hormones checked. We think about them playing with themselves during the week just to kind of like amp themselves up, or watching some porn, doing something that will bring their desire up. And that might be the route that we take. It kind of depends on the couple.
Great.
Okay.
Good job.
All right.
All right.
Great. Well, are you ready for this article then?
I am. I'm ready.
Okay, so I saw this. It's probably now a couple months ago, but I'm always on the lookout for testosterone articles that disagree with you, because I'm always curious.
Yeah. Okay.
Because I'm always curious.
What are you trying to say, Dr. Bailey?
Yeah, I'm just wondering. Did you miss something? Right. So,
am I wrong?
Yeah. Yeah. So this was, an article that screamed at me, association between testosterone replacement therapy and cardiovascular events in men. And basically their conclusion is essentially testosterone may be problematic. It's actually a kind of a strange article. Do you want to put your 2 cents in about what this was?
Yeah. Well, why do you think it's strange?
Well, because their conclusions, like this percentage is dangerous for this population and this percentage, or if let me say that, let's scratch that. Why do I think it's strange? What was your question?
Yeah. You said that you think that it's strange. Why do you think it's strange?
Well, because, their conclusion was you're kind of fucked either way. If you don't get testosterone and you need it, you're at risk for cardiovascular issues. But if you do get testosterone, you're at risk for cardiovascular issues. They're kind of saying like you're fucked if you turn left and you're fucked if you turn right. And they're saying that the research is inconclusive. Now, that one blew my mind, because what I hear from you is it's absolutely conclusive on this issue. So now they're saying the research is inconclusive. And I found this other article, which you probably know about, in the reference section. Was it Zohr, Z-O-H-R at all? Something like that? Anyway, because apparently they're saying a similar kind of thing. Zhao, Z-H-A-O.
Oh, yeah.
Yeah,
So
I knew you would know that.
So this paper is by, and the first author is Bal, B-A-L. Last author is Patel. And it's titled Association Between Testosterone Replacement Therapy and Cardiovascular Events in Men, a Retrospective Propensity-Weighted Analysis. That last part is sort of how they do the statistical approach. It's published in the Journal of Sexual Medicine in 2026. And I kind of let out a little bit of a groan when I saw this paper. And the reason is that, and I hate to say this, but this is not a good paper. It has a fatal, and what I mean by that is it has a fatal flaw that makes the analysis impossible to interpret. And the problem is not so much with the authors, but frankly, and I hate to say this also because they're probably my colleagues and I probably know them, although they're anonymous, with the reviewers.
Yeah.
So the Journal of Sexual Medicine is it's the Journal of the Sexual Medicine Society. and which is my society. And so here's the problem. Well, let me tell what the paper is and what they say, and then what the problem is.
Okay.
So this is a paper that looked at a database in Manitoba, the province of Manitoba in Canada, and they did two kinds of analyses. One was they looked at men who had a laboratory diagnosis, like a low level of testosterone. Um, they had a laboratory diagnosis of low testosterone. They compared it to controls.
Mhm.
Second is they took men who had prescriptions for testosterone and compared those to controls. And what they found, as you said, was that in both cases, the men with testosterone deficiency had more major adverse cardiovascular events, which is heart attack, stroke, and death, than the controls. Both for the testosterone group, guys who got testosterone, and the guys who had low testosterone.
Mhm.
And so their conclusions are, well, this is what we found, and we better tell men and caution men about the risks of testosterone. So, I like dissecting papers, and when I teach how to read a paper to other doctors, to residents, to medical students, the very first thing that's important is what are we looking at? Does this paper confirm something that we already know and provide a little twist on it, like a new population or something? Or does it contradict the existing literature? So to back up a second, the reason that I've said to you and on this podcast that the cardiovascular issue is done
Mhm.
is because it's done. and and it's not my say so.
Yeah.
So for the history of this is that for about now 30 years, there had been a slow but steady number of papers that were looking at the relationship between testosterone and cardiovascular disease, and it was uniform in that men with lower testosterone were at higher risk for everything related with cardiovascular events.
Mhm.
More atherosclerosis, more severe atherosclerosis, greater mortality, shown in sort of in high level studies, including meta-analyses, which are analyses of other studies, right? And so low testosterone is predictive of increased death, increased cardiovascular death, in
Mhm.
fact. So the only thing that changed it, why we even started talking about cardiovascular risk, was really because of this mainly one paper that's referenced here. The first author is vegan, and it's gotten notoriety now. And in 2013, it was published in one of the top medical journals in the world, JAMA. It was retrospective, which means it's not a study going forward, right, where we have a control group and, a placebo group and somebody else. So they look backwards in time and they have data. And what they reported was that men who got testosterone had more heart attack, stroke, and death than men who didn't. It turned out that it was I called this one not a very good paper. The other one was a bad paper. It made some really bad mistakes. Number one is they made a complete error in the reporting of their data, and they said it was more events. It was fewer events in that group. And in the end, they sort of admitted in response to letters to the editor, they reviewed their group and they found out that almost 10% of their study population that was supposed to be all male was female.
Yeah.
Like just not somebody messed up with the data collection, the data. It was just
So that too was a reviewer problem. The reviewers
But-
should have caught that.
absolutely. But that paper made major headlines.
Yeah.
Major headlines. And many people didn't and all people often know about papers is the first headline. The fact that there were problems that were discovered later, nobody sort of pays that much attention to unless you're in the field.
Right.
So the average person who's doing study on testosterone will see a paper on testosterone associated with increased cardiovascular risks in JAMA.
Well, so that's what got my attention with this article that, it's scaring doctors, I have to believe. Like, I get frustrated.
Absolutely.
You get frustrated with people our colleagues not getting on board
Absolutely.
with the healthfulness of hormone replacement therapy
Yeah.
when you're low. But, you see why doctors don't get on board because
So
their own medical journals
Yeah.
are are publishing this crap. And if I was a physician, I would be hesitant to prescribe because it's like, well, what if someone's then has a heart attack and they're going to say you caused it? Now you're going to probably have a legal problem.
Right.
So, I'd be like,
Right. So, right. And once these papers, so the only good thing about this paper is for the Journal of Sexual Medicine is it'll get a lot of citations.
right,
People will refer to this paper because look, if you
right.
want to make a claim, and I haven't told you what the weaknesses of this paper are, but if you want to make a claim that testosterone is dangerous, here it is.
Right.
There's an abstract. A medical student who's doing a presentation will find this, they'll present it.
Mhm.
Everybody they'll listen to will say, oh, here's a reference. It's in a good journal. And there you go.
So it's like, let's keep the fear alive because it's going to be good for our journal.
Well, I don't think anybody planned it that way or is thinking that way. I said it kind of tongue in cheek. It will be good for the journal. The journals all want citations. It has to do with their impact factor. But let me go back to why this
Okay.
story ended with the cardiovascular risk. So in 2015, the FDA said there is controversy around the risks of cardiovascular disease. Nothing conclusive, but there's controversy, and they forced the testosterone manufacturers to do what's called a large cardiovascular trial. It's a study to look at whether or not testosterone versus placebo was really associated with increased risk. It was called Traverse. It was the largest randomized control trial ever of testosterone. Over 5,000 people followed for an average of 33 months, almost 3 years. And they took men who had a lot of heart disease, so that they could have a lot of heart attacks and strokes and die. And in the end, the numbers of men who had a bad event who took testosterone was lower. Not significantly lower, tiny bit, but numerically lower than the guys who got placebo. 7.3 placebo, 7.0% testosterone. Not higher.
Mhm.
There have been several other randomized controlled trials, smaller, not designed to look at cardiovascular risk, but they show nothing worrisome. And there has been one large observational study after another that shows nothing.
Mhm.
There are several meta-analyses, and I just mentioned those, where they look at all of the randomized controlled trials. They try and put all those together. And there are, I forget how many, something like 10 or something. There's only one that shows anything, and that's the one that you mentioned.
Mhm.
So whatever it is, if it's 10, and I don't hold me to the exact number, 9 out of 10 show nothing.
Yeah.
So the story is kind of over. The problem with this paper, both in what they did and how they present it is they say, as you point out, the topic is controversial. It is not controversial anymore.
Right.
It's not. And one of the papers they cite to support their comment that it's controversial is the paper by Vegan et al. And JAMA,
Mhm.
that 129 medical societies petitioned JAMA to remove that paper because the data were not credible. After you find out there's so many women in it, like that's bad. Imagine a breast cancer study that
Oh man.
somehow negligently included 10% men, right? It's just not credible.
Yeah.
And the fact that they misreported their data. So that's their argument for the side that there's increased risk. It's actually very hard to find papers that show increased risk, especially for what we call MACE, major adverse cardiovascular events. So that's bad. The second is that if you're an author of a paper, and if any of you are listening in and you're writing papers, and you've got a result that contradicts what the previous literature has shown,
Mhm.
you better look at your data again. And if you think you're right, you haven't made some kind of error, then you have to explain it. You have to provide some rationale and say in the discussion
Yeah.
why this is different. These authors don't do it.
No, they
They
don't.
mention Traverse, but they say nothing about why their results might be different.
Yeah, that's true.
So they don't have a good reason. Now, here's why why their study itself is a problem and why this leads to it. So, we've held up randomized controlled trials as the gold standard because they do something that's really important, which is they try and control for all the variables that happen in populations. It's the knowns and the unknowns.
Mm.
So, for example, for cardiovascular disease, God forbid you have a whole lot of people who are diabetic, right? people with diabetes have more heart attacks and strokes than people with non-diabetes. So whenever you're looking at a study, you always want to make sure that some of the big things in your populations are relatively matched. If it's 23% in one population, it shouldn't be 53 in another, right? Like 27's okay, 21's okay, but it can't be hugely mismatched. And when you randomize, you hope that all those different factors will be roughly equal, but you have to make sure. When you don't do a randomized trial, and this isn't randomized, this is just looking at data, you want groups that vary by one different variable. They want it to be similar, but let's say one of them has, let's say, testosterone deficiency and one doesn't. That's fair. Look at the result. They did that. The second part is the problem I have. Is they looked at those who got testosterone versus those who didn't. So their controls are people so there's two variables. One is there's a medicine, and the other is there's a difference in the condition. Some people presumably got testosterone because they were deficient in testosterone. The other group is just whoever, come what may, right? So it's kind of like if we did a study looking at insulin use and heart attacks. If you had a group I would predict that the group that gets insulin compared to the natural population would have a higher event rate of heart attack, stroke, and death. Does that mean that insulin is the factor? No, it's the fact they're taking insulin for their underlying condition, which is diabetes. So if you take in an intervention, that's one variable, and then a different population, then you don't know what to make of this.
I see.
So their main finding was that men with testosterone deficiency, guess what, had more heart attack, stroke, and death. Okay, we've known that. That's consistent.
Yeah.
Testosterone deficiency is a risk factor for those things. Then they look at testosterone, but they're not looking at people who also are testosterone deficient, just those who got the medicine versus the rest of the population.
You know how else they defined it? Getting the medicine as being prescribed it twice in 1 year, whatever the prescription was. So that doesn't mean that they've been on it or on it for any period of time or were on it for the whole year or anything. Like, I don't know how they could use that as their...
Right. So having two prescriptions is better than only one. It means they at least refilled it. Somebody gets one prescription and they never get another one. You don't know that they ever had any exposure. But listen, let's say testosterone deficiency, which they've shown and many others have shown. So it's pretty much definitive now. Testosterone deficiency is a risk factor for getting bad events, cardiovascular events. Let's say it's possible that normalizing testosterone with testosterone therapy could help with that. But it's unlikely for it to help immediately. Right?
Right.
Like you have to reverse whatever made those people at risk. Maybe they've got more atherosclerosis. Maybe their coronary arteries have more plaque. Whatever it is that's going to reverse it is probably going to take time. So the more sophisticated way to do those studies is it's called to censor out the first year. Anything that happens, let's say in an initial period of time, doesn't matter. It's not included.
I see.
Because if it happened, let's say somebody has a heart attack 3 weeks after starting testosterone, or even 3 months, right? It's unlikely that testosterone did it or could have alleviated whatever the risk factors are. Not enough time has gone by for the testosterone to have made things better. In this case, what they've done is they've confused two things. They've made it as if testosterone is itself an issue.
Yeah.
And they haven't separated out from the population. What they should have done is taken men who had testosterone deficiency, some of who go on testosterone and some don't, and look at that population. And then you can start to try and get something there. Even those studies, there has to be a caution because it may not be random why some people go on testosterone and some don't. It may have to do with severity of symptoms or how low their testosterone is. So you have to account for all that. So in the end, my feeling about this is it's a shame that, frankly, that this went through the review process without the reviewers telling the authors that their analysis about testosterone treatment didn't make sense. Because you know what the authors could have done? They could have, this is a data set, a database thing. So they go back and they do a statistical analysis. There's actually no patients, right? You don't have to like collect the data over years.
Right.
They could go back and redo their analysis just looking at men who had testosterone deficiency. That might have been a useful paper. But this one isn't. I don't know what to do with that data.
So if you had this data, what would your conclusion be?
Well, the second part with regards to testosterone, I think it's uninterpretable. It's simply there's two important variables. I don't know what's what.
Yeah.
For the first one, it confirms what we know. Testosterone deficiency is an issue. The problem is that this paper will live on now that it's published, as an example of studies that testosterone is associated with greater, testosterone treatment associated with greater heart attack, stroke, and death.
Right.
And that it's an incorrect conclusion from this paper, and is contradicted by a tremendous amount of data that's already been published.
So if you were a reviewer on this paper, you would have said, go back. You need to redo
I would have said, I either rejected it outright, or I would have said, with major revision, you can't publish this unless you re-review your data with testosterone using the appropriate control group.
So I wonder if the reviewers read it carefully. I mean, I wonder, it's hard to review a paper. It takes a lot of time.
Yeah. So listen, I don't know who reviewed it, but listen, reviewing papers, there's a lot of statistical methods, and sometimes people are not that familiar with them.
Yeah.
Right.
Right.
So, and there are people here who are with epidemiology groups or public health groups, and you kind of assume they know what they're doing.
Yeah.
So the reviewers often will look maybe at the introduction and the discussion, and they'll nibble around the corners. But sometimes the design of the study itself is flawed, and that's the problem with this paper.
Yeah. Wow. And these are your Canadian colleagues too.
Yeah. Sorry, guys.
Well, I'm relieved because I was worried. Oh my God, I'm kidding.
Now, you know what'll be interesting is, in the testosterone world, so thank God for Traverse. Traverse really sort of, laid a marker in the ground. And I think it's going to be hard. And because we tend to value within medical science, we tend to value randomized control trials so much more than observational trials like this.
Yeah.
It's going to be hard now, since publication of Traverse, to value this kind of result as much as if Traverse hadn't yet been done.
Yes. Yes.
So this paper would have caused more trouble, if you will, and consternation before. But as you mentioned, the average doctor might see this headline,
and that's it,
and might say, I heard stories about this fit going back 10 years ago.
Right.
This seems to confirm my prior belief or fear that testosterone's bad.
Right.
And I'm just not going to do this.
Right. So it's unfortunate. It's really unfortunate. I'm sure we'll find more examples this year.
Always happens. There's always a paper.
Yeah. Well, I appreciate your feedback. That's one of the fun perks of being married to you, is I can give you any article, any piece of research, and you'll pick it apart.
Well, I don't mean to. Listen, and you can, and just to say something, there are papers where you can always find something to criticize in a paper.
Well, I don't mean that that's the way you do it, but you can take apart people's conclusions.
Yeah. But the most important thing to me is whenever I read any paper, my first question in my mind is, does this result make sense?
Yeah.
Given what we know about this problem. If you've got a result that is completely different than what the data have shown or what the best studies have shown, you got to figure out either what's wrong with your data, how your data might be true, but what makes them true? How do you understand that your results are different than what's gone before?
So what else is unfortunate is, we want to rely on science.
Yeah.
And this just shows yet again how even with the best journals and you would think the best reviewers were still getting data that we can't count on.
Absolutely. Yeah, and it puts me, so I strongly believe that we should follow the science.
Hmm.
That term has now become politicized
Yeah.
and mocked,
Yeah.
right?
Hmm.
So, and there's truth to it, but it gets taken too far. So the vegan article that I mentioned was published in the number 2 medical journal in the world,
Yeah.
or up there anyway,
Wow.
right? JAMA. Their reviewers are presumably top notch,
Hmm.
right?
Hmm.
So it was a very complicated statistical methodology, but presumably the reviewers knew it,
Yep.
right? And they missed it. And they had an editorialist who missed the thing. And the funny thing about that one was that unlike a lot of data, like they're giving you the results of their data, we don't have access to look at the nitty gritty of this.
Mm.
In the JAMA paper that caused the original problem, they gave you all the data you needed for their major conclusion. They said this many people had a stroke in this group, this many had a heart attack, this many died. And they used something called the absolute rate of events, which requires no statistical manipulation. It's just basically, like a percentage.
Mm-hmm.
If 10 people out of 100 had something, that rate would be 10%,
Mm-hmm.
right?
Mm-hmm.
And they gave it for the other group, and you could calculate it, and just in your head, you could do it. And you saw that their numbers were wrong.
Yeah, that's amazing. And
It's
it still got
amazing.
published.
Amazing.
Yeah.
Published in a major journal.
Yeah.
And they had multiple people who must have reviewed that article. So this stuff happens. And that's why I never believe one article.
Mm-hmm.
Never. It has to make sense given what we know about the existing data, or there has to be something radically different about methods or how they did it. Yeah. Anyway, those are my thoughts.
Well, thank you.
And for those of you who care, I think that this article does nothing to change the general gist of what it is we've been looking at for 10 years. Namely, testosterone therapy does not increase the risk of heart attack, stroke, or death.
But I think this is also like a wake-up call for all of us yet again, that we can't just trust what's published.
Right.
Just can't. We can't read an abstract and then go with it as fact,
Right.
even if it's written that way, even if the author's narrative is that it is fact.
Agree.
So,
read with caution. That's why I never believe one study. It's got to fit with other supporting data.
Mm-hmm.
Yeah.
Well, thank you, Dr. Morgentaler, for your insights.
Dr. Brandon, it's always a pleasure. And thus ends another episode of The Sex Doctors.
Yes.
And where can people find us if they want more of this content?
Yes, please come to our website, thesexdoctorspodcast.com, and subscribe.
Great. Well, thank you. We'll see you again for next time. Bye-bye.
Bye-bye. That we can't just trust what's published.
Right.
Just can't. We can't read an abstract and then go with it as fact,
Right.
even if it's written that way, even if the author's narrative is that it is fact.
Agree.
So,
read with caution. That's why I never believe one study. It's got to fit with other supporting data.
Mm-hmm.
Yeah.
Well, thank you, Dr. Morgentaler, for your insights.
Dr. Brandon, it's always a pleasure. And thus ends another episode of The Sex Doctors.
Yes.
And where can people find us if they want more of this content?
Yes, please come to our website, thesexdoctorspodcast.com, and subscribe.
Great. Well, thank you. We'll see you again for next time. Bye-bye.
Bye-bye.